So my name is Olivia Stanford. I'm one of the community health educators on the team of community outreach and engagement at Johns Hopkins Cancer Center. And we have with us tonight a couple familiar names or new faces for you. So I'll just allow my team to introduce themselves really quick. Dr. Brawley.
Well, I'm Otis Brawley. I'm Associate Director for Community Outreach. I am also a medical oncologist and epidemiologist. I'm a professor in the School of Medicine and the School of Public Health.
Excellent. Thank you, sir. And then Tiffany.
My name is Tiffany, and I am a community health educator in the Office of Community Outreach and Engagement.
Thank you both. So everyone, we have some other colleagues from our team on here, but we're going to hop right on into it because tonight we have Dr. Brawley for the next hour to talk with us about prostate cancer question. So some quick housekeeping. You might notice that you can't unmute yourselves or come off camera. And that's just so that we can really focus on the conversation with Dr. Brawley. But there is a Q&A function down below for you. So if at any point you have a question that you would like Dr. Brawley to answer, our girl Tiffany will be in the chat moderating. She will bring it to our attention. And Dr. Brawley is here just for that reason. So we hope you enjoy our Ask the Expert series for today. Before we get to the man of the hour, I will do a very brief presentation about the basics of prostate cancer. So we'll be right back with you, Dr. Brawley. So first, let's go into what you need to know about prostate cancer. First, I would touch on what is the prostate and what is prostate cancer. The prostate is a walnut-shaped gland that makes some of the fluid that is part of semen. And prostate cancer is the uncontrollable growth of cells in the prostate gland. In this picture on the right, this is a picture of where the prostate is located. And I put a dark colored box around it so you could see that this is the prostate gland. So now let's talk about risk factors. Risk factors are things that increase the chance of developing a disease or makes it more likely for someone to develop a disease. Today, we'll be talking about prostate cancer risk factors. So on one side are modifiable risk factors or things that we can try to control or change. And then on the other side are non-modifiable risk factors, things that impact cancer risk, but we cannot change those. Let's start with the things we can control or change. First is energy imbalance. So think of it like a three-leg stool. One leg is poor nutrition, another is a lack of physical activity, and that third leg is having excess body weight. That means being overweight or obese. So when those three factors that we can control are put together, that's called energy imbalance. We bring that to your attention because in the next 5 to 10 years, energy imbalance will become the new #1 cause of cancer in the United States. Dr. Brawley can touch more on that later on if you have questions related to that. So another modifiable risk factor related to prostate cancer is tobacco smoke or being exposed to tobacco smoke. So whether someone is smoking it themselves, so that's the firsthand smoke, or if others are around them are breathing in the expelled smoke, secondhand smoke, or if there's that toxic residue on the surface of furniture, walls, clothing, your hair, skin, and nails, any level exposure, there's no safe level. So those levels of exposure can increase a person's risk for prostate cancer. And then we have non-modifiable risk factors. So we talked about things we can try to change. Now let's talk about things that we can't, but they do play a role in prostate cancer risk. So the first is a person's age. A man can be diagnosed with prostate cancer at any age. However, as he gets older, the risk for prostate cancer does go up. Next is a personal or family history of prostate cancer. So if someone has been diagnosed with prostate cancer before, that's a personal history of prostate cancer. And if someone has a family history, that means they've had one or more immediate relatives. So think of a father, brother, a grandfather, uncle, or a son. If one of those direct lines related to you were diagnosed with prostate cancer, particularly at a younger age, then that increases that person's risk of prostate cancer as well. If you have more questions about family and personal history, Don't forget to drop it in the chat for Dr. Brawley to get to later. And then lastly is race and ethnicity. Men of West Sub-Saharan African descent are at an increased risk for prostate cancer as well. Now, you might have heard those risk factors and you may think that sounds like me, that sounds like someone I know, maybe someone you love, but just because someone has one or a couple of the risk factors, it does not mean that you will develop cancer for sure. On the other hand, for some people, they might not have had any of the known risk factors that increase risk, but that does not mean they will not develop cancer. That's why it's important to discuss screening options with your healthcare provider for prostate cancer, regardless of risk factors or what you think your risk level may be. And that's what forums like tonight is for you to ask those questions with an expert like Dr. Brawley. Now I'll briefly touch on some of the potential signs and symptoms of prostate cancer. Now, usually early stages of prostate cancer doesn't show signs and symptoms. However, more advanced prostate cancers can sometimes cause things like blood in the urine or semen, trouble getting an erection, having problems urinating, having an abnormal pain. So something that's not normal, a pain in the hips, in the back along the spine, or even in the chest area. There might be a weakness or numbness in the legs or feet, or a loss of bladder or bowel control. Now, after hearing all that, we did want to share this. There is suggestion in scientific studies that prostate cancer screening does save some lives. If you have questions about that statement, hold on tight because Dr. Brawley can answer more about that. Now, to quickly touch on the screening guidelines, the American Cancer Society recommends that men at average risk for prostate cancer can make an informed decision at 45 years old about whether they should get prostate cancer screening. Now, higher risk men may make the decision earlier at 40 years old. So that means that they have had the chance to speak with their healthcare provider about the potential harms, benefits, and unknowns, or those uncertainties associated with prostate cancer screening. That conversation may include information about the benefits of finding cancer early or the harms related to things like false test results, overdiagnosis, and overtreatment. So if you have more questions about those things, if you're wondering what do those mean, Dr. Brawley will talk about that soon. So these are the two types of prostate cancer screening tests that will be discussed today. Again, I will allow Dr. Brawley to really get into the nitty-gritty of these, but one is a blood test called a prostate-specific antigen test. And another way to screen for prostate cancer is the digital rectal exam, or the DRE. After prostate cancer screening, follow-up may include continued regular screening. So if no abnormalities are found from the result of those tests, you would just schedule your next regular follow-up screening. Or it may include medical testing or both. Now, we also want to touch on things like what happens, how do you diagnose prostate cancer? And what happens if I am diagnosed with prostate cancer? We'll allow those questions to be answered by Dr. Brawley because it's a little more nuanced than you may first think. And then last but not least, we have how to lower risk factors. How do we lower our risk? We talked about what prostate cancer is. We briefly mentioned those screening guidelines and the screening tests, but how do we bring down our risk for prostate cancer? Well, first, you want to aim for high quality routine screening, and you want to get into a program of routine screenings. That means that your qualified medical provider can have access to your past test results over time, so that if there are any changes, they can address them and then can help you decide what your next step should be. And then research shows that by improving your diet and physical activity, so by aiming to eat from the 5 food groups that you see on like all the My Plate charts and other things, by trying to reduce the amount of sodium and saturated fats that someone intakes and eating 5 to 9 servings of fruits and vegetables, and trying to get at least 30 minutes of physical activity a day. Doesn't matter what kind, just get up and moving. Though, before you start anything new, fellas, or anyone on this call, please consult your medical provider before you make those dietary and physical changes. But if you do that, if you smoke, limit smoking with the goal to quit and stay quit, Or if you drink alcohol, try to limit your consumption to recommended amounts. Recommended amounts of drinking alcohol, if you choose to drink, is 2 or less drinks per day for men. And I saw some other people on the call for women, that's 1 or less drinks per day. But if a man decides to drink alcohol, try to limit it to those 2 or less drinks per day. So that's like half a glass of wine, about 1 12-ounce can of regular beer, or 1.5 ounces of 80 proof distilled spirits. So research shows if you do these things, it can help lower your risk for prostate cancer. Thank you for listening to me for these last few minutes. My sources came from here, the National Institutes of Health, American Cancer Society, and others. So that is the end of my presentation. So we are all here to have your questions asked and answered with Dr. Brawley himself. I'm going to bring him back up on the screen. How are you this evening, sir?
Hello, thank you very much for a wonderful presentation.
Thank you. Thank you. So remember, everyone, as we have this dialogue tonight, we want to hear from you. So please use the Q&A function at the bottom of your screen and maybe on the side. And please drop your questions in the chat. We have some, so yeah, let's get started. So Dr. Brawley, after hearing that, pardon me. Thank you, sir. And thank you everyone for your patience. So Dr. Brawley, I guess the first thing I wanted to ask are, we know what the prostate is now and we know where it is in the body, but what are some of the common diseases of the prostate?
Sure, if I can share my screen here for a second, I'm going to show some pictures. And do you see me in presentation mode there?
Yes, sir.
Okay. The first thing I would note, you've already shown this schematic. You can see there's the bladder, and then urine comes from the bladder through the prostate. It's called the prostatic urethra. The urethra continues on through the penis and then urinate out the penis. Very common non-cancerous disease of the prostate that affects almost every aging man is called benign prostatic hyperplasia. And very simply, the prostate is like a donut, and we urinate through the hole in that donut. And very much like a pastry in an oven that's being cooked, as it gets bigger and bigger, the hole in the middle gets smaller. As men age, the prostate gets bigger and bigger, the hole that we urinate through gets smaller. And we can show you, there we have it. Here is the normal physiology where you have the bladder and then urination through the urethra, which is surrounded by prostate on all sides. Here you can see a swollen prostate that pushes down on the urethra. Men very frequently have difficulty urinating. We should stress that this is a huge problem with quality of life for many men, especially minority men in their 50s, 60s, and 70s. It's a quality of life issue more because people are hesitant to go to the doctor. Sometimes they're hesitant because they think it's prostate cancer. Sometimes they're hesitant because they don't want to talk about these sorts of things. People don't want to talk to other people, even doctors, about urination. I encourage men who have difficulty urinating to go talk to a doctor. There are some good, easy fixes. Some of them involve medications, some of them involve surgery, but we can improve an older man's quality of life quite easily. So, benign prostatic hyperplasia, a swollen prostate, prostatism, all of those are phrases for the same thing. It is not prostate cancer, but it is a problem that we can fix quite easily very frequently. Next question. I can't hear you.
Thank you. And that's why we have an amazing team. Thank you, sir. So for those of us who've just joined us, welcome to our Ask the Expert series. You have jumped right in at the beginning. Dr. Brawley just answered the question of what are some of the common diseases of the prostate other than prostate cancer. So our next question, sir, is, and before I get to that question, if you have just joined us, please don't forget to drop any questions you want Dr. Brawley to address in the chat below. So it's actually the Q&A function. So you can ask your questions directly to him or to any of our team that is here to bring them to attention. So our next question, Dr. Brawley, is what is the most important thing to know about prostate cancer screening?
The most important thing to know about prostate cancer screening is men, almost every organization has said a decision needs to be made about the age of 45 for most men, age 40 for men with a family history, about whether or not the man wants to get screened. This is called informed decision making. The physician and a patient ought to talk about potential benefits, potential harms, and there are some harms and some uncertainties about prostate cancer screening. The biggest uncertainty is there are a number of studies out there that have failed to show that prostate cancer screening saves lives. We can, if you want, get into the one study that does show that screening saves lives. And let me go to that. Okay. That one study, and how we do these studies is we take large numbers of men, in this instance, randomize them, half to get the screening test, half to not get the screening test, and look at them over time and see if there are more people alive in the group that got screened versus the group that didn't. This was done 12 times in Europe, Canada, and the United States in the 1960s and 70s to tell us that mammography saves lives. It's been done to tell us that cervical cancer and lung cancer screening saves lives. It actually has told us that some other screening tests don't save lives and actually can even cost lives. And so we've done this with prostate cancer, and there are a series of studies that have failed to tell us that screening saves lives. The one study that did tell us that it saves lives looks at a European population of 182,000 men aged 55 to 69 who were randomized to screening with PSA and digital rectal exam or no screening. And it showed, this is big science for saying, a 20% reduction in risk of death among the men who were screened. This is the only study that has ever shown us that screening saves lives. And this study said you need to invite 570 men to screening on a regular routine basis, not a one-time basis, in order to save one life. And you need to treat 18 men in order to save one life. This is the only study that tells us that screening saves lives. It in itself was controversial because it was done in a number of countries in Europe. And when you start looking at the data, screening only saved lives in the Netherlands and Sweden. It did not work in the other 6 countries that they did the screening in. So while we've got a number of studies that tell us screening doesn't work, we've also got this study, which also questions whether screening works. Now, if you believe this one study, it also tells us that if you screen 1,000 men on a regular basis, you will eventually diagnose 100 with prostate cancer. Now, we're starting to learn that there's a lot of people who have prostate cancer who don't need to be treated because it's never going to kill them. So the number of people that we're treating for prostate cancer is going down. About half of that 100 men who are diagnosed will be treated. About half will be watched and never treated. Eventually, about 4 out of the 100 will die from prostate cancer. Now, in the unscreened group, if you took 1,000 men who were on the unscreened group, about 60 are going to be diagnosed with prostate cancer due to going to the doctor for urinary problems and other things and has found that they have prostate cancer as sort of an aside. And 5 will die from prostate cancer, 5 per thousand versus 4 per thousand. That 20% relative risk reduction that we were just talking about is 1 out of 1,000. That is 5 out of 1,000 going to 4 out of 1,000. There, one life saved. Keep in mind that's at the expense of 40 more people being diagnosed because they were being screened. But as I noted, a large number of men who are diagnosed now, we watch them and we will never treat them. Uh, Now, people are shocked when they hear there's cancer that doesn't need to be treated because it's not a risk to the man's life. We've been told ever since we're on our mother's knee that all cancers are bad. It turns out that there are certain types of prostate cancer, and we're getting better and better at identifying them, that actually are not a risk to the man's life and can be watched. 20 years ago, every man who was found to have prostate cancer was told you need to be treated and you need to start treatment within the next 2 or 3 weeks. Today, half of all men who are diagnosed with prostate cancer are told we need to watch you carefully, but we're not going to treat your prostate cancer. If you want, I can also talk about how we treat prostate cancers when they're diagnosed.
Oh, we're definitely going to get to that. So you unloaded a lot, sir. We really appreciate having that information, especially learning how randomized clinical trials help to determine those guidelines. That was actually a question on how those screening guidelines got created. But one thing I did want to ask you, sir, is so if the data says that it saves some lives, are you saying that men shouldn't be screened for prostate cancer?
Well, what I'm saying and what the expert organizations have said, and there are about 12 expert organizations from the American Cancer Society to the American Urological Association. These are experts in cancer screening and treatment. They say not all men should be treated for not all men should be screened for prostate cancer. They say all men should be informed of the potential risks and the potential benefits. That man needs to weigh his concerns and then make a decision with their doctor about whether or not to be screened.
Hmm.
If a man wants to be screened, he should be encouraged to get screened and he should not be criticized. If a man doesn't want to be screened, he shouldn't be criticized for that either. It is a different conversation versus breast cancer screening or colon cancer screening, where there are numerous studies that tell us that it saves lives and it's net beneficial.
Okay, so it's definitely more nuanced. And like you've been emphasizing, is that important relationship with a provider that you trust. But, sir, for men who, or for patients who may not have access to that trusted provider relationship, is mass screening still a good option? Like I know at
Yeah.
malls and at different public events, they might offer mass screening, just.
Yeah, this is an unfortunate situation. All of those 12 organizations that I'm talking about say that this is so complicated, you should not be screening in a mass environment where a bus at a supermarket mall or a bus at a mall on a weekend or at a church service or something like that screening like that should not be done because men do not have the opportunity to have a discussion with the doctor and to weigh their own personal concerns and personal values. I know lots of people do that mass screening out there and they're well meaning, but we need to respect Black men, especially, and respect men and let men make the decision. And the experts have spoken. The experts have said, we can't make the decision for all men. Every man has got to make the decision for himself. And so this is I think, out of respect for what has happened in the past where people have been misled people have not been allowed to control their own bodies. We need to focus on this. And you raise a very important point. A large number of people do not have a doctor and do not have access to a doctor. That is a huge problem. I encourage all men to try to find a clinic, be it a federally qualified health system, uh, or something else, such that they can go talk to the doctor. You know, there's a lot of men who actually have insurance and can go see a doctor and choose not to. I think this is an opportunity for them. By the way, we've got good data to show that those men who go to the doctor are more likely to be diagnosed with blood pressure problems or diabetes more so than prostate cancer. And it is actually very, very important to realize that a man who is 50 years old is much more likely to die from cardiovascular disease and diabetes than prostate cancer. We have a large number of people who are very focused on prostate cancer and don't realize that diabetes, cardiovascular disease, and within the cancers, even lung cancer, is more likely to negatively affect them than prostate cancer.
Thank you, sir. So I do see some questions in the chat, so we'll get to those questions now. So one question says here, good evening, doctor. Does a patient with prostate carcinoma benefit from 5-alpha reductase inhibitors as a treatment option, as we do in the case of benign prostatic hyperplasia? Thank you so much.
Yeah, the 5-alpha reductase inhibitors, finasteride, trade name Proscar, or dutasteride, and I don't know the trade name of dutasteride, are used to shrink the prostate and open up the urethra so that a man can urinate better. Now, there's actually a study out there that suggests, or actually it shows, that those 5-alpha reductase inhibitors, these are pills taken once a day. You take finasteride daily for 7 years. It lowers your risk of both getting prostate cancer and it lowers your risk of ultimately dying of prostate cancer. Now that I've said that, I have to tell you, it's never been FDA approved for prostate cancer risk reduction. The study was done, but the data was never presented to the FDA, and the FDA never decided to approve it. Now, I treat a lot of prostate cancer. We typically do not use 5-alpha reductase inhibitors to treat prostate cancer. When we have metastatic prostate cancer, we do use some androgen blockers that are a little stronger than the 5-alpha reductase inhibitors. But the 5-alpha reductase inhibitors are FDA approved for treating that benign prostatic hyperplasia, BPH, or swollen prostate or prostatism that I talked about earlier. You're on mute again.
This is what we have fun with. Thank you so much, sir, for answering that question. And thank you so much for asking that question. So again, if anyone has some sort of question about prostate cancer, what it is, treatment, or even screening questions that maybe you would feel hesitant asking, when you ask your question in the Q&A, you can click anonymous. That way we don't know who asked it, but we can still ask Dr. Brawley because it's in the Q&A. Speaking of, oh, and let's see, we have a raised hand. So unfortunately, we cannot unmute people. This is like a webinar. We will work on trying to get that unmuted. I see you, Miss Betsy. Thank you so much for coming. Miss Betsy, are you able to type that in the chat? And if not, then we can again try to find a way to make sure that your question is answered and heard. Pardon me for that technical difficulty. Like I said, we're working to figure that out. In the meantime, do please feel free to try the Q&A at the bottom, but we are working on coming up with something for that. In the meantime, we do have another question. An anonymous participant asked, for men with cancer elsewhere in the body, will screening for prostate cancer too be a wise option? And this is with regard to concern for metastases of the prostate.
Okay. If someone has other medical issues, prostate cancer screening is usually not done. Uh, Most men who should be screened for prostate cancer are men who are fairly healthy, might be taking a little blood pressure medicine, a little cholesterol medicine, but men who have significant coronary artery disease, significant other types of cancer, screening is not for prostate cancer is definitely not going to be beneficial for them.
Okay, and so what is the most important thing to know, like talking of prostate cancer screening, if someone is in that relationship with their doctor, how would they talk to their doctor if the doctor hasn't brought up that conversation, those potential harms, benefits, and unknowns?
Yeah.
Yeah,
Yeah,
how
unfortunately, the situation is very frequently doctors only have 20 minutes with a patient. This is really a conversation you should have when the patient is undergoing a screening physical examination. And I would ask the doctor, uh, tell me about prostate cancer screening, or should I be screened for prostate cancer, or what are the controversies in prostate cancer screening? Or I've been considering asking you for prostate cancer screening. What are the arguments for it and against it? Those are all things that I would ask the doctor to talk about. If the doctor's not interested in discussing those with you, perhaps you need to find another doctor.
And that is a big ask, even though, like you said, that important relationship, especially with a nuanced disease. And as someone, I see a couple people have joined us. Welcome to our Ask the Expert series. We've had a couple questions from the chat with Dr. Brawley. So you will see that people cannot come off of camera or unmute themselves. But we do have a Q&A at the bottom of your screen. So in that Q&A, feel free to drop your questions for Dr. Brawley. We have a great conversation going here. And we are working to figure out to see if there is a way to let people off chat so that they can, speak with Dr. Brawley themselves. So after hearing all of those things, sir, what is the most important thing, since we didn't really talk about the treatment? You said something about watching and waiting.
Yeah,
So what
yeah.
is the
Mhm.
important thing to know about prostate cancer treatment?
Okay, let me go to, I think this is, yes. When we talk about prostate cancer treatment, uh, the treatment options for prostate cancer, I'm trying to pull that up right now. The treatment options, when one has localized prostate cancer, that is prostate cancer that is, I'm sorry, prostate cancer that is localized to the prostate. We've got, and this is another clinical trial that was done that randomized men who had been diagnosed with localized disease to either active surveillance or observation, radical prostatectomy, which is removal of the prostate, or radiation therapy, which is either external beam radiation like a chest x-ray where the x-ray beam goes into the pelvis, or the planting of seeds surgically in the prostate. Seeds are like little grains of rice. And following those men over time, and men who were given active surveillance had the opportunity to say, I'm tired of being watched, I want to be treated. Or if their disease started growing, they could be treated. And you can see that after 15 years of follow up, 2 to 3% had died in all of these arms. These are all thought to be equal. Should point out in active surveillance, about 20% of men said, I need to be treated, I can't take being watched anymore. And slightly less than 20% of men were treated because they were progressing. So of the active surveillance arm, greater than half did not get treated. Of the prostatectomy and radiotherapy arm, all of them got treated, but very equal risk of death. Now, this is for localized disease. For men who have disease that's busted out of the prostate, we'll treat that with radiation and hormonal therapy. The hormonal therapy is given for 18 months to 2 years. The radiation is given over about 6 weeks. For men who have metastatic disease, disease that has spread well outside the prostate cancer, oftentimes the bone and other places, we treat that with hormonal therapy, both a combination of pills and injections. But those are the major ways of treating the disease. When we look at treating with radical prostatectomy, cutting out the prostate, and this is one of the reasons why many men are don't want to get screened or frightened to get screened or don't want to talk about this. Some men who get radical prostatectomy end up with urinary incontinence or impotence, sexual impotence, small chance of rectal damage. About 1 in 200 who undergo radical prostatectomy die of the operation, not of the cancer. Of men who undergo radiation, we have urinary incontinence, impotence, and rectal damage is a problem as well. And men who end up getting hormonal therapy for metastatic disease, it creates issues with impotence, loss of sex drive, hot flashes, osteoporosis, which is bone loss, and it increases risk of cardiovascular disease. So these are the negatives of cancer treatment, prostate cancer treatment. Most men are going to get either radical prostatectomy or radiation. The question why the impotence issue, this is a drawing of nerves in yellow, arteries in red, and veins in blue. Here's the rectum here, and this is the prostate that's been isolated, and this is the urethra where urine would go on out the penis over here. When the surgery is done, they have to get in and they have to peel this nerve artery vein complex away from the prostate as they try to cut the prostate out. And if there's too much damage done to the nerves, arteries, and veins, then you end up with difficulty with both urine control after surgery as well as the impotence. I'll leave that so you can look at it some more.
Look at those colors. Every time I see these medical images, I'm in awe of people who are, they can understand them and break them down. So I thank you for touching on all of those things. And what I'm getting from this is that it just really emphasizes how nuanced, how intricate, how, that conversation is, and why it's extra important to really try and find that trusted patient provider relationship. So I will say, you briefly mentioned it, you briefly touched on, these are some of the reasons why, patients may be hesitant to even talk about prostate cancer. But what, as a practitioner, as an oncologist who sees patients, sir, what do you say to your patients who are hesitant about either prostate cancer screening or treatment? What do you actually say to your patients?
In the case of prostate cancer screening, I tell them about a very wise, not super educated patient that I came across about 20 years ago, who, after I went through, these are the risks, these are the potential benefits, these are the unknowns. He said, are you saying, in the question of should I get screened for prostate cancer, my guess is better than yours because I have to live with the end result? And I said, yes. And this guy chose not to get screened. Other people have heard the same thing and chose to get screened. If you're very concerned about prostate cancer, I think getting screened is a very reasonable thing to do. Like I said, those who choose to be screened should not be criticized. Those who choose not to be screened should not be criticized. Us in medicine who don't explain and give people the option should be criticized.
So pointing the questions a little differently, pointed at the ones who are hindering this healthy balance in relationship. Yeah. I see, and misleading the research and what the experts say. So that's a very hot take right there.
There
So,
tends to be a little bit of paternalism in medicine, which we need to get away from. Sometimes there's tremendous concern that people are being exploited. And interestingly, in prostate cancer, the exploitation is not respecting a man's right to determine what he does with his body.
that autonomy, that right to decide that I'm a human being, this is my body, and I get to decide at the end of the day what happens to it.
Yes.
Would you say, based off of your experience, or even if there's data on it, would you say that Black men have less opportunities for those, conversations than other groups or populations? I know we talked about men
Yeah.
of West Sub-Saharan African descent being at higher risk. So, is there any information on that?
Yeah, first in the United States, we have these racial blinders and we frequently say Black men are at higher risk. That's not true. It's Black men who are, his ancestry is from Northwestern Sub-Saharan Africa. It's important that we say it that way because Black men from Central Africa, from Eastern Africa, from Southern Africa have rates of prostate cancer that are different, lower than some areas of Europe. Uh, Black men from Northwestern Sub-Saharan Africa and much of the slave trade brought many people to the United States and indeed the Americas from that area, do have a higher risk. And we don't know why. It's probably familial, but we don't know why. What we do know is that once a man is diagnosed, and this is perhaps the best argument for screening in Black men, once a man is diagnosed, if he is stage 2 and he gets appropriate therapy from a good place, his chances of a good outcome are the same as a white man of the same stage. Equal treatment yields equal outcome among equal stage. Now, that being said, in the United States, Black men who are stage 2 have twice the risk of dying than white men who are stage 2. What I'm saying is good, high quality treatment is equally beneficial to Black and white men. And we have data to show that a substantial proportion of Black men, once diagnosed, do not get good, high quality treatment. It's actually, I've written about this. It's kind of ironic. There's a lot of people who are upset about informed decision making when it comes to screening, want all Black men to get screened. And then they do nothing to make sure that Black men get high quality treatment once diagnosed.
And isn't that often I caught myself that time, thank you, sir, but isn't that often just the assumption by someone that, oh, they can't possibly understand that, so I'm not even going to explain it.
Yes.
It's a, like you said, a paternalism. So thank you for breaking down what paternalism is and how that can impact health choices for anyone in different ways. So I did want to ask you, part of of tonight, we want to share knowledge with people. If they had questions, we hope that they're getting answered. We still have some time with Dr. Brawley. We still have 15 more minutes, everyone. So again, if you haven't done it already, definitely drop your question in the Q&A. It's not a chat, but it's very similar. But sir, just on the topic of people getting empowered, and they already have that power, we already have that autonomy and ownership over our bodies, but knowledge is also another form of power. So where are the best places to find information about prostate cancer?
Yeah. Well, I actually go regularly to the National Cancer Institute. That's www.cancer.gov. And they have something called PDQ, or Physician Data Query. You can look up prostate and other cancers there, and they have both doctor and lay summaries of both how the diseases should be treated. The data and the literature on prostate cancer screening can be found there. The American Cancer Society has been very good in this one particular area and in trying to explain and advocate for informed decision making. Their database and their website, which is www.cancer.org, is very good. Those are really two extraordinary places to go to get accurate information. I am very suspect of what we call Dr. Google. If you just go to Google and you Google something, you don't know if the source of information is high quality or not. Indeed, knowing oncology as I know it, I've seen some atrocious things just by simply Googling and not going to a good website.
Oh man, I call it Google University for, the way people look things up for academics. And now with the rise of technology like AI, and it's built into the search bar. So now the first thing people see when they go on Google are these compiled AI descriptions. And like you said, we can't really verify automatically off right that is high quality. So now just looking at the time, I want to just quadruple check. So while we wait for those last few questions, if anyone has them to go in the chat, I just wanted to let you know, thank you for joining us so far. We will continue this series. Next month, we will have a breast cancer specialist talk to us. And then in November, we will have a lung specialist to talk to us about smoking and vaping and lung cancer. The websites that Dr. Brawley talked about, we can send them out to you along with the slides and the link for tonight's recording. So let's see, any questions in the chat? Let's see, in the Q&A. Well, we've had some great questions already and great discussion. So sir, I guess I will end our time together. I like to ask a surprise question at the end that gets you thinking. You're so smart, so I'm hoping that you can come up with something good, no pressure. So sir, if you had 30 seconds, if you had one thing that you could tell people about prostate cancer, what would that be?
Well, if I only had 30 seconds, I had to talk about prostate cancer. You see, the first thing I would talk about is eat right. You talked about the three-legged stool, too many calories, not enough exercise, and storing that caloric energy. It's a huge cause of cancer. Smoking is a huge cause of cancer. Those are the things that are actually going to save more lives. But if someone is interested in prostate cancer, my 30 seconds are understand the potential benefits of screening, understand the risks of screening. Those risks of screening includes what we call overdiagnosis or diagnosis of a cancer that needs to be watched. Understand the importance of going to a good place and to get your prostate cancer treatment, and understand the importance of having a good relationship with your physician.
Wow, well, you definitely kept to that 30-second spiel. It's like you've done this before. Wow, who would have thought, Dr. Brawley? Well, everyone, we're not ones to just hold people here, though we do love to have a good time. So for that, we hope that you will follow us on social media. We have the same handle. It is Kimmel, COE. So that's KIMMELCOE. And that's on Facebook, Twitter, or X, and Instagram. We thank you so much for your time tonight. If you didn't have a chance to have your questions answered, please email us at kimmelcoe@jh.edu, and we will answer your questions via email and other means. So don't forget, come back next month to talk about breast cancer. And Dr. Brawley, we thank you so much for your time tonight.
Thanks for having me.
All right, everyone, have a good night. Take care.